Now, the last thing we need to look at with our treatment studies is, can I apply the study to my patient? Ultimately, it comes down to you and your patient and a question that you both share. So then you go to the literature to look up the answer, and that's when you pull up the paper. Now, in emergency medicine, it doesn't quite work like that, because the injuries and disease processes are such that you really don't have time to go look something up. So when we look at these treatment papers, we need to look at them with the perspective that this is what we're going to be using for future patients that we're going to see. It might not necessarily be the one in front of us, but maybe the one that we're going to see tomorrow or the day after or a month down the road. So for us, my patient means patients typical to those that I normally see. So to answer the question, can I apply this to my patient, we really want to ask 3 questions. Are the patients similar to mine? Were patient-important outcomes considered? And are the risks worth the benefits? So again, as we do the other questions, let's look at these each in turn. First, are the patients similar to mine? Now, in order to get into a study, every study is going to have inclusion and exclusion criteria. So a study might say we are only going to look at men between the ages of 20 and 40, and your patient is a 72-year-old woman. So that person would not have met these inclusion criteria. So the results of this study may not be valid for your patient. Now, the opposite is true too. They will also say they may exclude criteria. There might be exclusion criteria, like we're going to look at men between 20 and 40, but we're going to exclude smokers. So if your patient is a smoker, again, these results may not pertain to your patient. Now, that doesn't mean that you can't use the study. Now, you might find that there are no studies in which your patient would meet the inclusion and exclusion criteria. And so this might be the best evidence that you have. So your patient may not have all the inclusion criteria or may have a few of the exclusion criteria, but you might decide that, this is close enough, I'm going to use the results of the study anyway. And if that's the case, you want to ask yourself if there's any reason why you shouldn't use these results on your patient. And if you can't think of any, then go ahead and use them with a grain of salt, with the understanding that this wasn't designed exactly for your patient, but it might be close enough. Now, the next question you want to ask yourself is, were patient-important outcomes considered? Now, there's a couple of different ways to look at outcomes. There are disease-important outcomes or patient-important outcomes. Maybe there's a particular drug that will increase your patient's pulse ox, or even their PaO2. Now, those sound like great things, but what if despite that, the patient died anyway? So, really, which one does the patient care about? Do they care that their PaO2 went up? Do they even know what that is? Do they care that their pulse ox went up? They don't know what that is either. Do they know what it means to be dead? Yes, they do. So patient-important outcomes are things that are literally important to the patient. Will they be able to breathe? Will they feel better? Will they be able to go home? Will they be able to function normally? And the things that we often reassure ourselves with are the numbers, like the blood pressure went up or the heart rate went up or the creatinine went down. The patients don't care so much about that. If they go on dialysis, yeah, they care about that. The creatinine, not so much. So there are some drugs that'll take you from V-tach and convert you to sinus rhythm, but you'd still end up dying in the hospital. Doesn't matter. So what about surrogate outcomes? Surrogate outcomes are disease-important outcomes that we pretty much think are related to patient-important outcomes. For example, viral load in HIV patients. So we know that if we decrease the viral load, we're probably going to increase the life expectancy of a patient with HIV. So a particular study that shows that it decreases the viral load, well, does a patient really care about the viral load? Maybe they do, maybe they don't. What they do care is that they survive. And if we've pretty well established that viral load is going to increase survival, then, you know what? This surrogate outcome acts as a surrogate for this patient important outcome. And so the final question we need to ask is, are the treatment benefits worth the harm and the cost? Namely, you want to ask, is this worth doing? And this is a question that you have to ask the patient. And you need to know, what they want to get out of this, what the risks are, what the side effects are, and actually even what the monetary cost is. Now, a number that helps put this into perspective is something called the number needed to treat. And what this means is, the number needed to treat is, you need to treat this many patients in order to get one who will see the benefit. So let's say we have a number needed to treat that is 36. That means we need to treat 36 patients before we will see one who has any benefit. Compare this to a drug where the number needed to treat is 360. So now we need to treat a whole bunch of more patients in order to see any benefits. So it's much more rare that we're going to see that. So maybe it's not worth doing. Maybe the patient thinks, one of the side effects of this is that my hair is going to fall out, my teeth are going to fall out. And the chance of me getting any benefit is so slim, I don't want to do it. And the formula for this is 1 over the absolute risk reduction, or you'll remember that the absolute risk reduction really is the experimental event rate minus the control event rate. So let's look at another example. Maybe the number needed to treat for a particular treatment is 1,000. So you need to treat 1,000 patients to see benefit in one patient. But the cost is cheap. Maybe it costs $1, and the side effect is that your nose itches a little bit. So you discuss these harms and costs with the patient and tell them the number needed to treat. I mean, that's the benefit of this number. It's very understandable. It's very intuitive. And they decide, you know what? Let's just do it anyway. It's cheap and there's almost no side effects, so let's try it. Or maybe the number needed to treat is 10, meaning you only have to treat 10 people in order to see benefit in one. However, it's an expensive drug, and there's a 5% risk of death. And so you talk that over with the patient. They said, even though the benefit is, 1 out of 10 is going to get it, I have a 1 out of 20 chance of dying. I don't want to take that chance. I don't think it's worth that harm and cost. Now, the last thing I wanted to talk about is the difference between the relative risk reduction and the absolute risk reduction. And what does that really mean? Let's say we have a study in which the absolute risk reduction is 10% and the relative risk reduction is 50%. I'm totally making these numbers up, so I don't know what that would, if this came from anything. Let's just say these are numbers we have. How do you apply this to a particular patient? So the absolute risk reduction really refers to a group, to a sample or to a group of patients that you have. And it says that on average these guys are going to drop their risk by 10% by using this particular treatment. So what you're really looking at here is the average patient in the study. Now, in emergency medicine, that's what we're talking about, because we don't know what the patient that's going to come in tomorrow is going to be. So we just got to kind of look at the average. Who knows what the person in a month, their risk is going to be. But let's say you're in an office and you have 2 patients who come in with the same disease. So one patient has a risk of a bad outcome happening of 25%. You estimate that based on whatever, maybe your gut feeling, your experience with patients that you've had in the past, or maybe you have some sort of clinical prognostic scoring system that you put them through, but you come up with these numbers, 25% for one and 60% for another. Now, if you give both of these patients this same treatment, you're going to decrease their risk by 50%. So the first person, they're going to go from 25% to 12.5%. And the second person is going to go from 60% to 30%. So you drop this patient's risk down by a total of 12.5%. And you drop this one down by even more. You dropped them down by 30%. But all you've really done is taken them and dropped their what they started at by 50%. So relative risk reduction, you really apply to a particular patient. Absolute risk reduction, you're applying to the average patient in the study. And so that concludes this portion where we talked about, can I apply this study to my patient? And we looked at these three questions. Are the patients similar to mine? Were the patient important outcomes considered? And are the risks worth the benefits? As always, put any questions or comments down below.